I'm Sarah from crackasmole.com, and today's USMLE must-know topic, high-yield endocrinology pearls for the USMLE. First, the hypothalamus pituitary axis. When GnRH is pulsatile, it stimulates LH and FSH, but when it's continuous, it suppresses them, used in conditions like prostate cancer and endometriosis. Dopamine inhibits prolactin, but antipsychotics, which block D2 receptors, raise prolactin, leading to galactorrhea and amenorrhea. Next, diabetes insipidus. It can be central due to lack of ADH, often after trauma, or nephrogenic, resistance to ADH, often from lithium. Symptoms include polyuria and polydipsia with dilute urine. Diagnosis is with a water deprivation test, and treatment depends on the cause, DDAVP for central or addressing the underlying issue for nephrogenic. Pheochromocytoma, known as the 10% tumor, since 10% are bilateral, 10% malignant, and 10% extraadrenal. Patients get episodic headaches, sweating, and palpitations. Diagnosis is by checking plasma-free metanephrines, and treatment is surgery, but always block alpha first, then beta. Thyroid storm is triggered by stress, infection, or surgery and presents with fever, tachycardia, and agitation. Treatment order matters. Start with a beta blocker propranolol, then PTU, iodine, and steroids. In the anterior pituitary, we have hormones like TSH, ACTH, and factors like TRH and CRH. The posterior pituitary releases ADH and oxytocin. Cushing syndrome, it's excess cortisol from either an ACTH adenoma or exogenous steroids. Patients have central obesity, moon face, buffalo hump, and Purkinje stria. Screen with a low-dose dexamethasone test. Confirm with a high-dose test plus ACTH measurement. Treatment is addressing the cause, often surgery. Calcium regulation. In primary hyperparathyroidism, there's a parathyroid adenoma raising PTH and calcium and lowering phosphate. In hypoparathyroidism, often post-surgical, PTH and calcium are low, but phosphate is high. Mixed edema coma is a severe form of hypothyroidism. Patients are hypothermic, bradycardic, and confused. Treatment is IV levothyroxine, hydrocortisone, and supportive care. Thyroid function tests. TSH is the best screening tool. Free T4 and T3 help interpret primary hyperhypothyroidism as well as other states. Cortisol peaks in the morning. It's low in Addison's disease and high in Cushing's. Diabetes mellitus pearls. Type 1 is autoimmune, often young, prone to DKA. Type 2 is insulin resistance, usually older, prone to HHS. Cushing's with low-dose dex test, pheochromocytoma with plasma metanephrines, acromegaly with IGF-1, Addison's with morning cortisol, diabetes insipidus with a water deprivation test, and more. High-yield hormone facts. ADH increases water reabsorption, aldosterone raises sodium and lowers potassium, and prolactinomas, most common pituitary tumor, cause amenorrhea and galactorrhea. Acromegaly, which we see from a pituitary adenoma, leads to increased growth hormone and IGF-1. Patients typically have enlarged hands and feet, coarse facial features, a protruding jaw, and even carpal tunnel syndrome. Diagnosis involves checking IGF-1 levels, and you confirm by seeing if GH is not suppressed during a glucose test. Treatment often involves surgery or medications like octreotide. So thyroid disorders revolve around either too much or too little thyroid hormone. In hypothyroidism, you have insufficient thyroid hormone, which can cause fatigue, weight gain, cold intolerance, and depression. Common causes are Hashimoto's thyroiditis or iodine deficiency. Hyperthyroidism is the opposite, too much hormone. Symptoms include weight loss, heat intolerance, anxiety, and a rapid heartbeat. Graves' disease is a common cause here. And then you have thyroid nodules or goiter, which can be benign or malignant. So diagnosis usually involves TSH, free T4, and sometimes antibodies. Treatment depends on the cause. Hypothyroidism often uses levothyroxine, while hyperthyroidism might use antithyroid meds like methimazole or even radioactive iodine. Men syndromes. Men1 includes parathyroid adenomas, pancreatic tumors, and pituitary adenomas. Men2A is characterized by medullary thyroid cancer, pheochromocytoma, and parathyroid hyperplasia. Men2B includes medullary thyroid cancer, pheochromocytoma, mucosal neuromas, and a marfanoid habitus. Then for PTH, it increases calcium and phosphate, decreases blood glucose, increases bone resorption, increases potassium, lipogenesis, and vitamin D activation. Insulin decreases blood glucose, increases glycogenolysis, gluconeogenesis in the kidney. GLP-1 and GIP are incretins that rise with hypoglycemia and amino acids. Medications, methimazole is used for hyperthyroidism but can cause agranulocytosis, hepatotoxicity, so check CBC and LFTs. PTU is another option, especially in the first trimester. It also blocks T4 to T3 conversion. Cabergoline, a dopamine agonist, is used for prolactinomas. Side effects include nausea or the static hypotension. Octreotide treats acromegaly, VIPMs, and carcinoids. Side effects can be gallstones, GI upset. Hydrocortisone replaces cortisol and aldosterone in adrenal insufficiency, especially in a stress dose during a crisis. Fludrocortisone is a mineral corticoid replacement, often in Addison's disease. Watch for hypertension, edema, and potassium changes. And the classic mnemonic, stones, bones, Brones, pike. Stones refer to kidney stones, bones to bone pain, groans to gastrointestinal symptoms, and psych refers to depression or confusion.